you so much. We'll move on to Dr. Gangadhara Sundar, who is from Singapore, and he's going to talk about retinoblastoma in Asia, and his discussant would be Dr. Seema Das from Shroff Charitable Eye Hospital, New Delhi.
Thank you, Santosh and Fairuz and Team AIOS for organizing this on the occasion of the World Retinoblastoma Week. I think it's starting tomorrow. And hats off to all the pioneers who have paved the pathway for our better understanding and management. A big thank you for training Dr. Santosh Unawar, who has completely transformed the way we understand and manage retinoblastoma. So thank you very much. Greetings from Barcelona. Warm Barcelona. It's a lovely, bright evening over here. I'm here for a facial trauma conference. But I'll share my personal perspectives, what I've experienced in the past 18, 20 years since I moved to Southeast Asia. People talk about the global burden of retinoblastoma, but actually when a patient comes to us, if we see a disease as a burden, then it conveys a negative image. And I think as all of you are pioneers and leaders and masters in the management of the disease, we have to probably change the word of burden to the joy and the satisfaction that we get from delivering very good outcome. The major problem is that it is relatively a rare disease, and hence even departments and institutions and even governmental organizations sometimes don't pay as much regard to this disease, whose incidence is 1 in 12 to 15,000 live births, resulting in a global incidence of about 9,000 per year. But what is most important is 4 billion of the 7 billion population lives in this part of the world, and hence these kind of webinars and conferences are very important. I'm not going to touch about what happens in India and China, but these are big countries where the retinoblastoma is managed uniquely. But what I'm going to touch upon is my personal perspective on the Southeast Asian perspective. Neither do I have a conflict of interest, no interest in conflict that we see in this part of the world. Of course, the only conflict I'm interested in is where it actually fosters science and knowledge and discussion, education, and helps humanity. So it is really a success story. A 90% mortality disease has transformed to a 90% survival disease. I would probably dare say it's probably the most curable malignancy. And the treatment paradigms has always focused towards life first, followed by globe and vision. But I'll probably qualify it and redefine it a little bit more as we go along. We at NUH Ophthalmic Oncology Service draw patients from all these countries that I've highlighted over here, including Pakistan, Russia, and a few other countries. With our birth rate of only about 45,000 babies every year, we see about 2 to 3 babies, but about 12 to 15 patients that we see from the region almost every year in the pre-pandemic era. And this is our NUH retinoblastoma team. We have our pediatric oncologists here, two retinal surgeons here, pediatric ophthalmologists here, and hiding silently behind us, the intra-arterial team, Dr. Anil from the neurointerventional radiology team. We used to take a lot of pride in saying that, yes, we manage this disease very well. Yes, this child post-enucleation with a prosthesis, customized prosthesis, and this is how we are managing it in the early 20s, and we said, yes, we did a great job. But what has transformed in the past about 8 to 10 years, at least years, now with the introduction of intra-arterial chemotherapy, we are not only saving eyes, lives, globes, and even vision is being restored. And this has been really gratifying, as Dr. Carol Sheets was demonstrating earlier on. So how did we get here? We started off with enucleation, external beam radiation therapy in the 20s, 50s, cryo and photocoagulation came in, and the Shields, I think, kind of introduced the concept of chemotherapy, but we now call it chemoreduction. And of course, Dr. Munier and all the other pioneers have taught about intracameral, intravitreal chemotherapy and entering the posterior chamber of the eye through the cornea are all fantastic ways of doing it, but there's still a role for enucleation in some of these patients. So what is the problem with enucleation? Because in the past, the ophthalmologist just enucleated an eye and said, I've done a curative procedure. But now in the modern context, number one, these are potentially avoidable. And that's why it leads to a lot of conflicts between the patients and the families and the primary ophthalmologist who only offers enucleation as a therapeutic intervention. There are numerous barriers which can be societal, religious, psychosocial, economic barriers, and that kind of varies from the country to country, from where our patients come from, depending on even the religious background, where they are averse to having any organ being removed from their body. And if the organ is removed, they actually want the organs back for burial purposes so that they can meet the religious requirements. The third major challenge is this issue of the family, and usually the Asian context is an extended family. In other words, the family is no longer the child and the father and the mother, but the uncle and the aunt and the neighbor and the grandparents, all of which adds to the complications that we face in the discussion itself. And a major complication that we also encounter is the ego of the primary ophthalmologist, the surgeon, he or she who actually stands their ground and insists this is the only way to treat the child, when the parents now in the internet era are able to go read up on Dr. Google and find there are far better ways of treating the patient and the child without necessarily having to remove the eye. So that's an important barrier that we see in this part of the world. And finally, most importantly, there are patients who end up having deaths despite enucleation. Dr. Ralph Eagle showed that the importance of high-risk characteristics. So if you did not have a dedicated ophthalmic pathologist, you did not define this, you just remove the eye, send the child back to the village saying that you're cured, and lo and behold, the patient has intraorbital disease, intracranial disease, and death. That conveys a wrong message to the patient and the family that even after removing the eye, the child is probably not going to be cured, and hence it's a barrier for enucleation. There's no active monitoring the cut end of the optic nerve. There's no follow-up post-enucleation in some of these patients. And pre-enucleation staging errors where people end up doing a CT scan, not an MRI. And MRI, they don't really visualize the intracranial structure, including looking for the trilateral retinoblastoma, but only image the orbits looking for orbital extension. Here, examples of patients where children have been cured unilaterally. As you can see over here, even this patient even had radiation, the residual consequences of the face, or a child who came to us post bilateral enucleation as the only treatment modality that is offered. When the parents came to us for a second opinion, what else can you do except to rehabilitate this child? Hence, enucleation is not the end of the story, even if you cure this child. So I always believe that when you do an enucleation, the life, globe, vision, then socket rehabilitation becomes a very important armamentarium in the tool in the management of retinoblastoma when the child has to go back to the school, not disfigured. So there are papers which we talked about the differences between the developed and the developing nations, the average age of diagnosis in a developed or high income country compared to a low income country. The incidence of orbital disease is far much more in the low income disease itself and extraocular disease. So these are very important perspectives that we still see in this era, even the 2000 era. And if you look at, except for barring India and China, there's approximate incidence and number of cases that we see in this part of the world. And we see about 3 or 4 times the average incidence that we see in Singapore itself. And this is the group of patients that we end up either offering telemedicine consultations or management, and a huge slew of challenges that we face in this part of the world. So how do retinoblastoma kids really suffer in this part of the world? In Asia Pacific, where there's no formal training for ophthalmic oncology, there's no ocular oncologist. Children often suffer from sometimes no management at all because the diagnosis has been wrong, or they've been offering the wrong treatment. They have been incompletely treated, or they end up being poorly treated. And there are a lot of these physician factors equally to blame as the patient family factors. Here's an example of a child who came to us then in the pre-IAC era with an advanced group DE retinoblastoma. The other eye is completely normal. We managed with the enucleation. And based on the history that the first child had indeed ended up having an enucleation, this is a post-enucleation retinoblastoma with orbital intracranial extension where the child had died. And based on that, when the family had a third baby, neonatal screening and acute screening in the first 2-3 months, we were able to identify the child's early lesion and treat it with local consolidation therapy without systemic chemoreduction. Here's another child who was actually referred with a retinoblastoma, but actually it was not a retinoblastoma, had undergone intravitreal injections for quote-unquote retinal disease or Coates disease because he was a 5-year-old child. The retinal surgeon did not think of a diagnosis of retinoblastoma. And by the time he came to us, he had extensive orbital disease, metastatic disease, and finally the child died. And a third example of a patient who actually had extensive orbital disease, Dr. Honavar has published beautifully on orbital disease and how it can be managed. Here's a child running around the family where the chicken were literally picking on the maggots, which is on the surface of the lesion, where we actually debulked the tumor completely, instituted high-dose chemotherapy based on the protocol. But when he went back to the village, based on the complications of the chemotherapy, which was not being monitored by the primary pediatrician and the pediatric oncologist, the child ended up succumbing to the disease itself. So the factors that we face are challenges are physician factors, where either the pediatricians or the family physicians either are not aware of the diagnosis of retinoblastoma, or they tell the child, don't worry, it's just a strabismus, can be fixed later, send the child back home. Or sometimes they end up seeing an ophthalmologist who's not a pediatric ophthalmologist or oncology trained, who ended up misdiagnosing and sending the child back home. There may not be facilities for anesthesiologists to give examination to anesthesia. So that's why we believe even a sedated examination saves not only the cost, but morbidity of these patients. And finally, the physician ego factor. In addition to the patient factors and system factors, where Not every institution has multimodality, multidisciplinary teams, and it takes an effort to build these teams, which sometimes it takes 5, 7, 10 years to find the right person in every specialty. And finally, cost consideration and technology considerations, because cryo, laser, although not that expensive, sometimes are deemed as expensive technological treatment therapies. And of course, IAC is a new factor, which I think was talked about by Dr. Mahesh. What are the factors, again, which cause challenges in management? Diagnosis or misdiagnosis of true versus pseudoretinoblastomas. Grouping and staging are oftentimes not well understood and not well performed, both clinically and radiologically itself. Management is oftentimes suboptimal. And of course, the most important thing is follow-up. Just enucleating or treating the child and not making them come back for regular follow-ups results in challenging disease. We do have cases where they're rightly diagnosed, but have inadequate management, where because of incomplete treatment of the retinal tumor, child, instead of coming back in 3 weeks or 4 weeks or 6 weeks, coming back for regular follow-up, disappears for 6 weeks, 6 months, and comes back with extensive disease, where they start treating with focal treatment when it's not going to work anymore. Sometimes the diagnosis is right, but the management is wrong, and every once in a while it's a wrong diagnosis. What are the system factors? And this is personally what I faced as well. It took about 10, 15 years for me to motivate one of our own residents in our own residency program to pursue the concept of ophthalmic oncology. Doesn't make easy money, and it's a lot of hard work. It's passion which drives you to do it. Concept of an ophthalmic oncologist who's both comfortable with both intraocular and extraocular disease is very important. The government priorities of focus towards rare diseases is very important. Sometimes they pay attention only to the local patients, but not to the foreign patients. Not all ophthalmic institutions have support services for pediatric patients. And finally, the ophthalmic and oncology partnership or the multidisciplinary teams. And that's a team that I'm now very proud of. We now have a young bunch of pediatric ophthalmologists, young vitreoretinal surgeons. Dr. Gopal has been guiding them. Pediatric oncologists, we have an interventional radiologist on board. Like the pathologist, ocularists need is becoming lower, but we still do it. That finally the pathologist and the geneticist. So what are the suggestions to overcome the challenges here? These kind of conferences and webinars, especially in the COVID era, is very, very important. We need to have formally trained ophthalmic oncologists, like every one of you who's got wonderful training. We've had the Shields over here who have trained Arun Singh and Fairuz and Santosh and several other people, Dr. Abramson, Dr. Geeta, for example, who's trained Kaustav, for example. These are the people who really should be transforming the way Asia-Pacific retinoblastoma management is concerned. These are the retinoblastoma programs we've had over the years, and we're going to be having one very soon. So in summary, I would say that retinoblastoma should not be seen as a burden anymore, but actually a joy and satisfaction to treat. Encourage young people to take up this. It is very satisfying when you manage it very well with a multimodality, multidisciplinary approach. Also, the take-home message is enucleation, not the end, but merely a step in the management of these patients as well. And finally, when you have to enucleate, do not forget that socket reconstruction is just as important as enucleation in confirming this management. Thank you very much for the kind attention. And I'll end up with this slide from Barcelona over here with Anthony Gaudi, where this building is ongoing work for the past 10 years. To do something right, first you need love, and I say passion, and then technique comes in. Thank you very much, and I invite you all to our retinoblastoma symposium, which is happening very soon. Thank you very much.
Ganga, very nicely put. Seema, ready to discuss?
Thank you very much, Dr. Ganga, for sharing your experience and also suggesting a solution. This is something which is so much relatable to what we see in India. It's almost the same story and the same scenario most of the time. So I would just like to share our experience and a few interventions, what we are kind of currently doing to sort of tackle these issues of the non-clinical factors, the barriers so-called, which comes in the way of giving an optimal treatment to these patients. So these are some of the stories I'm sure all of us can relate to that. This child was in fact saw during the COVID time, where the child was diagnosed when the tumor was already inside the eye, and as part of the protocol, he was sent for an MRI. Now the MRI center, when the child went, was shut down because of COVID, because they were not giving anesthesia. So, and they didn't bother to kind of go back to the treating physician or find out an alternative center. So they came back after 9 months after the lockdown was over, and that's when the MRI was done, and this is what the picture is, and we know the outcome. So a lot of lack of awareness, and even the diagnostic facilities are something which is a big hindrance, at least at the initiation of the treatment. Other scenarios like this family has a father, both are enucleated, 2 siblings at presentation, bilateral retinoblastoma. to offer the prenatal diagnosis when the mother was expecting the third child. Though it was positive, we explained the prognosis. Despite that, they refused a termination of pregnancy and went ahead. But fortunately, we knew that this child is going to have to treat it on time and pick it up on time. But for this child, every time, you can imagine the number of times they had to shuffle between the hospital and home. And every time we had to support them, not only with the sort of, lodging, accommodation, food, but also with the transport. Otherwise, they just refused to come for the treatment. So again, very familiar scenario, which I'm sure many of us might be facing, at least in this part of the world. Other thing which you have highlighted, residual tumor following incomplete surgery, because many times the protocol of treatment is not followed. And this is the picture after the chemo reduction when we started the child, and we can clearly see the whole optic nerve there. And this was an eye which was possibly eviscerated, not even enucleated. So there are a lot of issues which includes right from breaching protocol, lack of awareness, and other barriers. And one of the intervention that we are planning under the aegis of the retinoblastoma stakeholder group is to plan a prospective study to see the epidemiological and the clinical features and what is the outcome if we all can follow a standardized protocol. So we started, the study was started towards the end of 2020. It is still enrolling patients. And one of the objectives of the study was not only to kind of see the outcome, but as the study is sort of, held by CanKids, and this is under the aegis of the Indian chapter of the pediatric oncology, the research wing of it. In fact, Dr. Santosh is the PI of the study. One of the objectives is if we prospectively follow this patient, we might be able to do the intervention if there is a barrier. We might be able to identify it and then kind of address the barrier. So this was the major objective. And right now we have 19 centers. Most of the major centers treating RB in the country who are enrolled for this study. As of now, we have enrolled about 530 patients, and we still have the data which are kind of yet to be analyzed. But preliminary, what we see, 20% still have extraocular representation, which is what we also tend to otherwise see in our clinical practice. The figure might be a shade better than what it was maybe 5 years back, but 20% extraocular is not something which we need to kind of see. Good part is, as of now, though, just about a minuscule of them have completed treatment, just about 8%, but as of now, the treatment abandonment has been just 2%. So we are keeping our finger crossed, and we need to see when these patients follow up, whether all of them are able to complete the treatment and get a protocol-based treatment or not. This study, the genesis of this was actually our experience in supporting these barriers. And this was what we did after the experience of the COVID. And this is our 1 year data about what we found when we sort of, a little bit of more handholding is done for this patient in terms of, travel, accommodation, investigation, and most important, the counseling, which is aimed at improving the compliance. So over a period of, this is our data of 2021, and what we found that out of the 73 children which we could treat in this period, our compliance earlier used to hover somewhere about 80% or so. But when we identified some of these barriers by having a dedicated counselor who could follow up those patients and a coordinator, and most of these patients had some kind of barriers, but almost the compliance right from 80%, it actually increased to about 92%, which in our context is a pretty good picture. Another intervention we've kind of, has done in the last year, which might be an option which we can consider at least to incorporate it in the government screening program, is screening for the white reflex. And this is something which can be very easily done even by the community health workers. And as part of our network, we have network of secondary centers apart from the tertiary care center at Delhi. And we have trained them to look for white reflex in a child's eye when they go for the pediatric eye screening for other things like, squint and other things. And this device, the ArcLight, is something which is kind of, very cheap sort of, ophthalmoscope, which can be used even by a community level health worker to screen it. And this is again something not a great number, but out of the 7,000 children or so which has been screened till now, we could identify at least one child with a white reflex who turned out to be a bilateral retinoblastoma. And the important thing is the other sibling of the child, when we screen that one also as part of the screening, again had bilateral retinoblastoma. So at least out of those 7,000, 2 child could be picked up and sort of, saved. At least the eye could be saved, probably their life also. And this is something we can kind of, advocate for incorporating in the other pediatric eye screening programs of the country. So these are our experience and some of the things which, in addition to what you have mentioned, which probably we can sort of incorporate in our treatment, along with our clinical treatment, and the management of RB goes well beyond the clinics. And a little bit more handholding is required.
Thank you so much, Seema.